for giving this opportunity. A big round of applause for our HOD. So I'll give the due credits to Dr. Arshid for this presentation, and the video credits also go to him. So my topic is laparoscopic intracorporeal rectus aponeuroplasty. It's a novel approach, as Dr. Sarfaraz was saying, that we have to make it, the hernia surgery has to be made easy. We don't have to complicate the surgery. There are many surgeries, and nowadays it is becoming more and more confusing. Since this laparoscopic ventral hernia was reported by Leblanc and Booth in 1993, a myriad of procedures have been invented. And every now and then, every day, we are seeing new and newer approaches being adopted. Almost less than 500,000 of surgeries, hernia surgeries, are being done every year in the United States. So when we are at crossroads, what to do? You have all these: anterior component separation, posterior component separation, you have ETEP, Rivas Stopa, you have TAM, you have TAPP, you have SCOLA, and many things, IPOM, I+. And to add confusion to the story, we are presenting this laparoscopic intracorporeal rectus aponeuroplasty. So why is the need? Why should we go for this thing? IPOM, as you know, that there may be a central mesh failure. There may be a pseudo recurrence. IPOM plus, the closure is difficult. There sometimes the defect is big, and when you are doing an IPOM plus, there is a lot of tension on the defect, and you are closing it. It may result in the recurrences. It may result in the more pain. So this was a gentleman from Spain, J. Gomes, who came up with the concept of this laparoscopic intracorporeal rectus aponeuroplasty. A brief account of these procedures. ETEP, Rivas Stopa. You need support initially. You need to watch the stalwarts of the field to do this surgery. You need their guidance. And then you need help. You need to operate under their guidance. And then you need a proper assistance. You see, when you are doing Rivas Stopa, there is a seroma formation of 5%. Most of these seromas do not need any treatment, as has been classified that class 1, 2, 3 seromas usually do not need any surgical intervention. But it's class 4 where there is an infection and you may need to remove the seroma. And then it is associated with the complications. The more dreaded complication, the Cleveland Dindo third and fourth complications, which need an intervention, and where there may be an organ failure, there may be a multi-organ failure. These have to be treated. And the incidence of these in this procedure is 1%. Intraoperative complications range up to 2%, conversion rate is 1%, mean hospital stay is around 1.7%, and recurrence at 6 months is 1%. So this is the technique. What we are doing in this. This is a small video. This is not my own video. This is from the Department of Surgery. The credit goes to Dr. Arshid and Dr. Hamid. So after entering the peritoneal cavity, you see there are multiple adhesions. You have to take down these adhesions slowly and securing the gut if the gut is adherent, and you have to delineate the defect. After the delineation of the defect, you can do the measurements, whether you do it preoperatively, you do it intraoperatively, and defects up to even 8 to 10 centimeters can be dealt with this technique. You are raising the flaps, you are making a longitudinal incision almost 1 to 2 centimeters away from the defect. This is for midline hernias, but this same concept can be extended to the lateral hernias, or even this concept can be extended to the M5 hernias. This usually we are doing for M2, M3, and M4 hernias. So after doing this, raising these flaps all around the defect, as being beautifully demonstrated here, there are multiple techniques of suturing it. Here what we are doing a loop technique. We are just keeping the thread suture outside and only inserting the needle inside. And we are using a loop suture. The needle is passing through the loop to anchor it, and then the medial edges of this flap are with the pressure. Here the pressure has to be maintained at the same. We are using a 15 millimeters of mercury pressure. You have to keep the same, and you start suturing the lateral edges of the this flap. Go on suturing it using horizontal mattress sutures. from below upwards, whatever it is easy. It can be used by, it can be sutured by other methods also, like you are using the barbed sutures, V-lock sutures, and many other techniques. But the problem with those sutures is that you have to pass in the whole suture into the peritoneal cavity and then handling becomes little difficult. But whatever way is easy to you, you can do that. After completing this suturing, you can lower the pressure. You can decrease the intra-abdominal pressure to 6 to 8 millimeters of the mercury. You take one end of the needle out and pull it. So here is this defect being closed in front of you without much of the dissection, without much of the this complications of seroma, bleeding, and other things. And then conventionally, what you are doing in an IPOM, you put in a mesh and secure it in place. This is a simpler technique, as Dr. Sarfaraz was saying, that you have to simplify the procedure. You don't have to make it more and more complicated. Now, giving the little bit of the data from our department of the surgery. This is the mesh being fixed by the tackers. So this is the data from our department. Till now, 37 patients have been operated. And this is an old data. By now, the score is more than this. But this we have analyzed it. These were M2 and M3, M2, M3, and M4. Defect size was 4.4 to 7 centimeters. Mean defect is 5.2 centimeters. Operative time, mean operative time was 67 minutes, means around 1 hour. Seroma formation was there in the 4 patients which were managed conservatively. Hospital stay, mean hospital stay is 1.3 days. So you can discharge these patients in on first or the second post-operative day. 1 year follow-up of 15 patients, there is no recurrence. So the results, initial results are very encouraging. And I think we should go on continuing with this procedure. This is a new addition to the already existing hernia condom. Familiarity with the anatomy, closure without tension are the main benefits. Evidence is accumulating and we are all still at the crossroads. So the crux is that we have to focus. If we are lost, we have to focus, rethink, and redo the things. Thank you very much.
Very nice presentation, Michael. I have 2 questions. One is, what is the level of the depth of the incision which is made all around the defect? And the second question, after applying the tackers, there is still a potential space left between the mesh and the edge.
Mesh and the?
Can be done between the edge of the mesh
and
the peritoneum. There is still a space left.
No, there is no space left. Basically, what you are approximating, the incision which you are giving around, the mesh covers that incision wholly. So there is no space left between that. So regarding the depth of this is the peritoneum and the posterior rectus sheath. As I am saying, that the concept same, although we are not using it for M5 hernias or the L hernias, the lateral hernias, but the concept then can be later on extended to those M5 and the L lateral hernias also. I hope